Good afternoon, everyone. So my role is basically to set the stage for the, and these are my disclosures, set the stage for the other presentations, or sort of a general talk on the impact of diabetes in cardiovascular disease. And so I start with a few statistics. As you well know, and we've known that since the days of the Framingham study, diabetes is an independent risk factor for cardiovascular disease. Actually, people with diabetes, unfortunately, are somewhere between 2 and 4 times more likely to develop cardiovascular disease than those without diabetes. We also know, obviously, that diabetes is has major microvascular complications, first cause of blindness in the world, first cause of renal failure leading to dialysis. But obviously, we know that cardiovascular disease is the most common complication of diabetes, with more than 2/3 of diabetics actually dying from cardiovascular disease. And then also the risk of cardiovascular disease mortality is more than doubled in patients with type 2 diabetes versus age-matched control. So right then and there, these are statistics that most of you know well. We realize the importance of diabetes in leading to cardiovascular disease. Actually, I could have chosen a lot of slides, but in this brief talk, these are data that you probably know well from the Emerging Risk Factor Collaboration, published some years ago in the Lancet. More than 500,000 participants, where, as you see on this slide, you see hazard ratio for vascular outcomes in patients with diabetes versus those without diabetes. These data have been adjusted for a number of important risk characteristics: age, sex, blood pressure, smoking, and BMI. And the take-home message, basically, as you see here, with a large number of cases of a robust analysis, basically approximately a twofold increase in the risk of dying from coronary heart disease, from suffering from myocardial infarction, but also from suffering from strokes. And interestingly, both ischemic strokes and hemorrhagic strokes were increased in patients with diabetes compared to those without diabetes, and similarly for other causes of vascular deaths. So then, very simple question, and then I'm going to try to link the two, diabetes and acute coronary syndrome. So for those of you be less familiar with the cardiology side of this, well, actually, when we talk about acute coronary syndromes, we basically are talking about, in broad terms, a group of disorders that are caused by acute myocardial ischemia due to atherosclerotic coronary disease, most often caused by the rupture of a fibrous cap overlaying a rich lipid core, and this leading to a superimposed thrombosis and reduced coronary flow. And we basically divide, in general terms, ACS into STEMIs, so patients with ST segment elevation myocardial infarction, non-STEMIs without ST elevation myocardial infarction, and unstable angina, that is those, as you'll see in a minute, that do not have increases in plasma biomarkers. We know that acute coronary syndromes do cause significant morbidity and mortality, and they're actually responsible for approximately half of all cardiovascular disease-related deaths. So this is a significant portion of what we take care of as cardiologists. Now, in terms of the spectrum of ACS and how we determine how to diagnose basically the different entities, well, basically most often a patient will come in with chest pain or some equivalent of chest pain, whether a patient comes in with shortness of breath, typically, or other similar symptoms. This will lead to a working diagnosis of an ACS. One of our simple but very useful tool, obviously, is the electrocardiogram. If there is persistent ST elevation, typically in at least 2 leads, well, this is sufficient to diagnose ST segment elevation myocardial infarction. And then if you do not have evidence of a persistent ST elevation, then we really rely on cardiac biomarkers, and nowadays mostly troponins, to determine whether the patient has non-ST elevation MI, if he or she has a significant rise in troponins. If the patient has evidence of coronary ischemia with or without ECG abnormalities, but no evidence of cardiac biomarkers being abnormal, then we will call that unstable angina. But as you will see a bit later on, with the advent of high sensitivity troponins, actually this entity has become much less common, and we are seeing more and more of non-STEMIs now that we have high sensitivity troponins. Just in terms of the burden of acute coronary syndromes in the world, you see a few statistics here. 2004, ischemic heart disease was the leading cause of death, which it still is in the world. The World Health Organization has reminded us of that just last year. And ischemic heart disease was the 4th leading cause of burden of disease. Actually, epidemiologists are predicting that about 15 years from now, ischemic heart disease will have become the 2nd leading cause of burden of disease. So this is not going away, despite our best efforts for the time being. As I said earlier, acute coronary syndromes still account for about half of all of the deaths related to cardiovascular disease. And about 15%, 1/5 of patients with acute coronary syndromes actually will die or will experience a reinfarction within only a month of the diagnosis. So again, despite our best efforts, both medical and interventional, we need to do better with these patients. There's still a huge unmet residual risk. In terms of a few EU statistics, the number of deaths in the first year following an ACS ranges from somewhere around 20,000 patients in Spain to over 90,000 in Germany. Obviously, some of these statistics depend on the number of people in a given country, but this is obviously highly relevant. In terms of costs, ranges per episode of ACS somewhere between 7,000 and 12,000 euros. And then in terms of the total cost, economic costs of ACS in the EU in billions of euros, as you can see here, it ranges somewhere between 1 and 3 billion, 3.3 in Germany, 3 in Italy, about 2 in the UK, 1.3 in France, and $1 billion per year in Spain. And then turning to the US, a few statistics. ACS, acute coronary syndromes, cost approximately $150 billion per year in the US. As you can see here on this slide, approximately 20% of men and women above 40 years of age are actually predicted to die within a year of their initial myocardial infarction. And importantly, 20% or so of patients with ACS will need rehospitalizations within a year, and this leads to this is a major cost driver in the healthcare system. In terms of relative prevalence of the different components of ACS, STEMI, non-STEMI, and unstable angina, and again, taking into account that with the increasing use of high sensitivity troponins, the incidence, the prevalence may change just a bit, but these are useful numbers. If you look at relatively recent registries, the GRACE registry, the Your Heart survey, and we have similar numbers from the US actually. Somewhere between 25 and 40% of cases of ACS actually are STEMIs. Very similar numbers, non-STEMIs, and the rest is actually unstable angina. But again, reinforcing that this number is likely to go down with high sensitivity troponin. These are numbers I think are important. Actually, the incidence of myocardial infarction remains high, somewhere around 250 cases per 100,000 person years. It has gone down to a certain extent, but what is interesting actually, the pattern has changed. I think most cardiologists have experienced this. STEMIs have gone down, but basically non-STEMIs and unstable angina have gone up, and this trend is actually increasing. So basically the relative incidence of STEMI versus non-STEMI has gone down because this is going down and this is going up. Whether this is related to the aggressive prevention, including high-dose statins, smoking cessation, blood pressure control, diabetes management, is not entirely clear, but I think that this has played a role in the different profile that we've seen in the last 15 years, that had evolved over the last 15 years. Now, I've said a few words about diabetes, a few words about ACS, now trying to link the two. We know that diabetes is an important risk factor for acute coronary syndromes for a number of reasons. There's clearly a high prevalence of subclinical atherosclerosis, meaning patients have plaques in their coronaries, often without having any symptoms for decades. And this is even more true in patients with diabetes. Again, in patients with diabetes without a clinical history of CHD. We know, unfortunately, that coronary disease, here it says TENS, but I think we can say that is more severe in patients with diabetes. We know that the disease is not only more severe in percent stenosis, but also the disease is more diffuse on the angiogram. And we and others have also shown that actually both fasting blood glucose and glycated hemoglobin are associated with the progression of coronary disease. And I want to acknowledge Colin Berry, who is a cardiologist now back in Glasgow, but it did this work with us in the Montreal Heart Institute. So in that study that we've performed, the higher your HbA1c and your fasting blood glucose, this was actually significantly correlated with progression of coronary disease 2 years down the road. Also, we know that diabetes is associated with increased risk of ACS. And once you unfortunately suffer from an ACS, diabetes is also associated with a higher risk of dying or having a reinfarction after that initial index acute coronary syndrome. And similarly, unfortunately, diabetes is also associated with a greater risk of complications, and we'll come back to that in a few minutes, but also bleeding and heart failure. I've mentioned that diabetes is an independent predictor of mortality globally in CVD, but this remains true also in patients with an acute coronary syndrome. And actually, much like with the global statistics for CVD, patients with diabetes unfortunately have a twofold higher risk of dying after an acute coronary syndrome. And finally, I suspect that you know that statistic well, approximately 20 to 30% of patients with acute coronary syndrome, both non-STEMIs and STEMIs, suffer from diabetes. But as you well know, this is just the tip of the iceberg, because an even greater number of patients with ACS have glucose dysregulation. And this is just one example illustrating that diabetes is associated with poorer outcomes after an acute coronary syndrome. Actually, rapidly, you see the curves diverging. Patients with diabetes, whether treated with insulin or not, rapidly within just a few weeks compared to those without diabetes, have clearly an increased risk of severe outcomes after the initial acute coronary syndrome. And here in this slide was the probability of dying or suffering from a reinfarction. And again, you see the curves diverging within less than a month. If you have diabetes, you're at a much higher risk of having recurrent events after the initial index event. Now, not only this is true for diabetes, but also hyperglycemia per se has a major impact in acute coronary syndromes. Again, as I alluded to just before, hyperglycemia is very common in patients admitted to hospital for acute coronary syndromes. Approximately 2/3 of patients with acute myocardial infarction, even not known to have diabetes, do have impaired glucose regulation when they're given a glucose tolerance test. This has been shown in all parts of the world. We also know that hyperglycemia on admission for ACS strongly predicts poorer survival and increased risk of all sorts of cardiovascular complications. Not only that, but actually persistent elevation in blood glucose right after an MI also is associated with increase in hospital mortality. It is actually the persistence of blood glucose elevation is actually a better predictor of bad outcomes after an MI than the initial blood glucose upon admission. Unfortunately, hyperglycemia, I think, probably remains underappreciated as a risk factor for ACS and is frequently untreated. And as you will see, and as you'll hear from the other speakers over the next 2 hours, I think the management of hyperglycemia after an acute coronary syndrome is an important clinical issue that does need to be addressed. So why are patients with diabetes at increased risk of acute coronary syndromes? Well, I think this is multifactorial. I've listed, I think, the most important causes on this slide. Certainly, patients with diabetes not only have insulin resistance, but they also have so-called atherogenic dyslipidemia. Typically, these patients have high triglyceride levels, high ApoB levels in plasma, often high non-HDL cholesterol levels in plasma, and this is often commonly associated with a low level of HDL cholesterol. So they have insulin resistance, they have dyslipidemia. As you well know, they have a number of comorbidities that do increase their risk of poor outcomes. They have more renal dysfunction, they have more hypertension, and they also at increased risk of heart failure, which dramatically increases the risk of complications and risk of death in patients after myocardial infarction. And finally, we know, and we've known for a long time, that type 2 diabetes is also associated with a pro-inflammatory and pro-thrombotic states. We know that patients with diabetes and acute coronary syndromes actually have a greater proportion of plaques that are ruptured or ulcerated. These are the plaques that are leading to acute coronary syndromes most of the time, and a higher prevalence of intracoronary thrombi, clots, than patients without diabetes. So really a number of reasons underlying the major increased risk for acute coronary syndromes in patients with diabetes compared to those without diabetes. So just a few, this is a simple overview of how we treat acute coronary syndromes. Again, my task was just to an introduction about diabetes and acute coronary syndromes. You'll hear a lot more about this throughout the symposium. So basically, in general terms, our goal in patients with STEMIs, most of the time you've got a completely occluded artery and time is muscle. So basically what we want to do is, as cardiologists, is to restore adequate coronary blood flow as quickly as possible, most of the time using mechanical revascularization, most of the time primary angioplasty as opposed to CABG surgery, because this is the most efficient, rapid way we can do this. In some parts of the world, some sites are still using thrombolytic therapy. A lot of hospitals have stopped doing that a long time ago. When you have access to mechanical revascularization, you can rapidly restore blood flow without exposing the patient to increased risk of intracranial bleeding that you get with fibrinolytic therapy. And so, for example, in my hospital, we've stopped using fibrinolytic therapy more than a decade ago. So the take-home message is we quickly want to restore blood flow in patients with STEMIs. As far as non-STEMI and unstable angina is concerned, well, typically you have a bit more time to intervene, unless the patient has a mechanical complication or is extremely unstable. So typically what we want to do in the short term is to alleviate ischemia and symptoms, and typically we do that by performing coronary angiography in the vast majority of patients, and in those in which it is appropriate, we perform revascularization on a semi-urgent basis, with in mind the fact that a number of studies have suggested that bypass surgery actually beats PCI, coronary angioplasty, in patients with diabetes. So we'll tend, if patients have several plaques that are severe and several vessels that are affected, we will often tend to favor surgery compared to PCI because of a number of studies, including most recently the FREEDOM study. And then here it says unstable angina, but we could have said that for all acute coronary syndromes. Actually, what we want to do then is to reduce the risk of future recurrences, and you'll hear about this also later on. And this really requires a multifaceted approach that includes dual antiplatelet therapy, a powerful statin, a RAS inhibitor, either an ACE inhibitor or an ARB, as well as control of all cardiovascular risk factors. So just giving you a bit more details about STEMIs and non-STEMIs. In general terms, in terms of treatment guidelines, patients comes in with acute chest pain or equivalent, often shortness of breath. You have a working diagnosis of ACS. In a very short term, you want to relieve pain, anxiety, shortness of breath, often with nitroglycerin and morphine. In the case of STEMIs, basically what we will do, typically in most parts of the world, what we do, the emergency technicians in the ambulance will basically send the ECGs on our intelligent phones. We look at that immediately, and if there's evidence of STEMI, we ask that the patient be sent directly to the cath lab. We perform the angiogram, and if we indeed, in most cases, will be able to reopen the vessel, perform primary angioplasty, and restore blood flow. This is basically how this is done. We obviously have to manage in the appropriate patients the additional complications that may occur, whether it's heart failure, if patients go into cardiogenic shock, if there are mechanical complications like VSDs or mitral regurgitations and arrhythmias. Obviously, we'll be very aggressive with antiplatelet therapies, most often 2 antiplatelet agents, aspirin and a P2Y12 inhibitor. And then in the later stage, when the patient becomes more stable, I think that part is also extremely important. So ambulation, start talking about physical activity, start talking about longer-term risk assessment, lifestyle advice, and secondary prevention. And this will be key, long-term control of risk factor using a multifaceted approach. In the short term, we restore flow, but this is not going to cure disease. We then need to focus on all of these risk factors. As far as non-STEMIs is concerned, as I said earlier, we have a bit more time to intervene. Often the patient will be put on 2 antiplatelet agents, again aspirin and a P2Y12 blocker, ticagrelor, prasugrel, or clopidogrel, as well as antithrombotic treatments, whether it's unfractionated heparin or low molecular weight heparin. Then we will proceed often the day after to coronary angiography, and if deemed appropriate, revascularization. As I said earlier, in patients with diabetes, if you have 2 or 3 vessel disease, especially if there are several severe stenoses, because of different trials like FREEDOM, we will tend to send more patients to bypass surgery. And then once again, that last step of hospital discharge and post-discharge management actually will be key. Just a couple of simple notes. Basically nowadays, after early revascularization, basically routine monitoring beyond 24 to 36 hours is no longer warranted. However, the risk of recurrences, especially in diabetics, unfortunately remains elevated over particularly the first 6 months after the initial event. And as I said, intensive risk factor modification and lifestyle changes are required in all patients. And I think that cardiac rehab programs after discharge are important, not only to start physical activity, but also can enhance adherence to medical treatment and may also support better risk factor modification. So there are general recommendations for glycemic control in patients with cardiovascular disease. And this is a paper just a few years ago from Lars Redan. The first recommendation being that patients with cardiovascular disease should be investigated for disorders of glucose metabolism. So if you allow me, what I did, I took this presentation of recommendation from Lars and I just reordered them to something that makes a lot of sense to me in terms of orders of priority. So first, yes, investigate patients for disorders of glucose metabolism, for lipid abnormalities and blood pressure. But then in terms of drug therapy, aspirin first is indicated in patients with diabetes and coronary artery disease to reduce the risk of cardiovascular events. In patients with both diabetes and acute coronary syndrome, certainly most of these patients will be put on a second antiplatelet agent, a P2Y12 receptor blocker. So again, ticagrelor, prasugrel, or clopidogrel, for example. So most often, 2 antiplatelet agent. Aggressive use of powerful statins at high dosages to reduce the risk of cardiovascular events. In most patients with diabetes, think that a RAS inhibitor, an ACE inhibitor, an ARB is indicated in patients with diabetes and CAD based on the HOPE and Europa trials in particular. And then beta blockers should be considered to reduce morbidity and mortality in patients with diabetes and ACS. And this is particularly true in patients with myocardial infarction, particularly true in patients as evidence of left ventricular dysfunction. So basically, this is sort of the Fab Four, if you go back to the Beatles era. So antiplatelet agents, statin therapy, RAS inhibition, and beta blockade. So then in terms of general recommendations from that paper, well, insulin-based glycemic control could be considered in patients with ACS with significant hyperglycemia. And then glycemic control, and this obviously will be the object of discussions over the next 2 hours, which may be accomplished through a number of ways, should certainly be considered in patients with diabetes in the context of an acute coronary syndrome. So there are general recommendations. Then there are also recommendations for the management of diabetes, specifically after a STEMI. These are guidelines from the European Society of Cardiology. You have a few specific measures that have been proposed, realizing that this actually dates back from 2008. So obviously lifestyle changes in conjunction with pharmaceutical approaches. Here it says to achieve HbA1c less than 6.5. Obviously, need to be careful in terms of the age, for how many years the patient has had diabetes, the number of complications, to make sure that we do not increase the risk too much of hypoglycemia in these patients, which make us all very nervous. I think obviously we want to intensively modify all other risk factors, and that means the aggressive use of statins for dyslipidemia, aggressive control of blood pressure, obesity, and importantly also smoking cessation. And finally, I believe that this also can be combined with coordination with physicians specialized in diabetes, obviously. So there are general guidelines, but actually no specific guidelines on the long-term management of diabetes in patients after an acute coronary syndrome. So again, this is a fairly recent paper. Again, dual antiplatelet therapy, statins, RAS inhibition, beta blockade, lifestyle changes, risk factor counseling, referral to cardiac rehab, and other secondary prevention programs, but no specific guidelines. And I think now with all these large outcomes studies that have been recently reported, and also some of them being reported at this meeting, I think that we will need more more precise guidelines as to how to add this into our therapeutic armamentarium in patients with both diabetes and ACS, because I think that this lack of clear guidance as to how to use these agents may be contributing to some of the poor outcomes of patients with diabetes and ACS. So we know that patients with both diabetes and ACS clearly are at higher risk for both short and long-term cardiovascular events. They do require aggressive pharmacological and invasive management, aggressive secondary prevention. However, we also know, unfortunately, that patients with diabetes and ACS appear to be suboptimally treated compared to those without diabetes. The The commonly cited example is that these patients are being less frequently prescribed P2Y12 blockers, sometimes for good reasons because they might be at increased risk of bleeding, which is also a predictor of future events. But I think we need to realize the importance of dysglycemia and diabetes in patients with ACS and be even more aggressive in those patients. And so to summarize and sort of set the stage for the other speakers, the journey of the patients with acute coronary syndrome and diabetes, in summary, diabetes is clearly an independent risk factor for cardiovascular disease. And cardiovascular disease is common in patients with type 2 diabetes. As you've seen, diabetes increases clearly the risk of ACS. And once you have an ACS, drastically increases the risk of poor prognosis, increasing the risk of death, MI, heart failure, and other complications. While guidelines do provide fairly comprehensive recommendations for the management of acute coronary syndromes in general, we actually, as I just said a few minutes ago, we have very limited specific guidance on patient management for patients who have both type 2 diabetes and ACS. And so despite patients with diabetes and ACS being clearly at higher risk of short-term and long-term cardiovascular events, unfortunately they remain suboptimally treated compared with patients without diabetes. They clearly remain at a high residual risk, and we need to be doing more for these patients. I thank you for your attention.
Thank you very much. Questions? You have a couple, actually 3 microphones in the back and 3 in the front. So if you have questions for Dr. Tardif, please walk to the microphones. And while you make up your minds, could I ask a question? Some years ago, there was a trial in ACS, DIGAMI, which was carried out in this country with really very encouraging results, and this was called DIGAMI 1.
Correct.
Which was then followed by DIGAMI 2, and these were insulin trials, because as you said, the treatment of the diabetes itself, the hyperglycemia, and the context of ACS is uncertain to some extent. So, what 10 or 15 years later, what's your take on those?
Well, my take on, these were interesting, important studies. As you well said, the second larger study, the DIGAMI-2, did not confirm the findings of the first one. There was quite a bit of excitement of this GIK approach when we saw the DIGAMI-1 results. And actually some people were already starting using it, but I guess it's fair to say when we all saw the results of the second study that were fairly disappointing, I think the enthusiasm around that approach has decreased. This is certainly not something that we're using widely, for example, in my institution after MI. The other thing that has changed over the years, if you think about how we were treating acute coronary syndromes and STEMIs, I don't know, 15 years ago, patients were staying 7 days, 8 days. Now the mean duration of stay in the hospital after ACS is something like 2.2 days. So things are, patients get in, they get their cath. Not to say that they've been cured, but what happens is in a busy cardiology hospital, they get diagnosis, they get cath, and there's little time. So the dynamics, it's not only, and I think we need to factor this in, the reality of how we treat these patients nowadays. So the stay after MI now has become much, much more shorter. And I think it increases the challenge on all of us to not have the patient just leave and think that he's been cured because we've put in 1 to 3 stents into their coronary arteries, because the journey has just started. And it's difficult. The patient is stunned, has had morphine, has had PCI often, and then the day later he's been, he's being told to just go home with 7 new pills if he's a new. So there are a lot of information that needs to be absorbed from the patient. There's a major challenge there.
But what do you do for their diabetes in those 2.2 days? Well, you work them up in terms of, do they have diabetes? Do they have complications of diabetes like renal failure or dyslipidemia, etc.? Perhaps other relevant questions would be how long they've been diabetic, whether they have a family history, joint family history of diabetes and cardiovascular disease, which seem to conjure together. But then at your institution, what do you do for the diabetes itself? Do you stop the medications that they were on? Do you start them on insulin? What's
yes.
Yeah.
So I don't want to steal the thunder of the other speakers who I believe will be addressing this, but in a nutshell.
But in Montreal, yeah.
Yeah. So in a nutshell, basically, no, we don't stop the medications that are there. Well, first of all, a lot of patients are diagnosed with, newly diagnosed diabetes at the time of an ACS. A lot of patients like this. In terms of those with established diabetes, most of the time we will not be stopping their drug. Most often they're on metformin and 1 or 2 or 3 additional drugs for their diabetes. Most often it's a collaboration between the cardiologist and the diabetologist. So we engage in a discussion. I have to admit, as a cardiologist, I will not initiate long-term insulin therapy personally, but we collaborate closely with our endocrinologists and diabetes specialist colleagues. Most often this leads to more aggressive therapy before they leave the hospital. But more importantly, I think the key message for these patients, in my mind, is that a lot of patients have this magical sort of mindset that, the cardiologist has fixed my disease. And it's important for patients to understand that this disease is not going away. We fixed 1 or 2 vessels. Now we need to enter into this long-term relationship to prevent recurrences. We clearly reinforce that. It's about diabetes management, lipid management, blood pressure management, smoking cessation. All of that is important. And yes, all of these patients are being released rapidly, but most of the time, within 2 to 6 weeks, will be seen both by a cardiologist and the endocrinologist.
Very short question, Doctor. It's about chronic management of coronary artery disease beyond the primary angioplasty. There is still debate whether revascularization in this patient is better with angioplasty or CABG, and it's debated, including within our cardiology community. Mm-hmm. What is your stand on that?
Well, in the context of diabetes, since this is a talk about diabetes and ACS, as I said, I think the result, I don't know what you think, Fayez, but the results of the FREEDOM trial have really influenced me greatly. So it's not black and white. I mean, there are trials, and then it's what you do in the cath lab, which I suspect is what you want me to say. So it's not black or white. In a cath lab, you have a patient. What I think FREEDOM has done, the FREEDOM trial, is if you have multi-vessel disease, a lot of plaques that are severe and complex disease, you will tend much more to refer for CABG surgery. This is not to say that if you have an easy, mid-LED, tight stenosis, easy to revascularize, I mean, we still do these cases, but FREEDOM has taught us, and a lot of other studies as well, but has taught us that the more severe, more multi-vessel disease, you'll tend to refer these patients now to if they're diabetics. I don't know if you agree, but that's how I'm practicing now. And the Barry trial had suggested the same thing some years ago. But FREEDOM has really changed. I think was a game changer in my mind for patients with both diabetes and established coronary artery disease. Would you agree with this, Fayez?
Yes, totally. It's just that there is a big pressure from interventional cardiology to keep up with the angioplasty revascularization. As you mentioned, This is great for elective, very localized stenosis, which is not so common in diabetes. They tend to have multivessel, etc. So it's good to restate that in the diabetology audience that, yes, cabbage is the preferred option for vascularization in many diabetes.
Oh, absolutely, absolutely. And the other thing I would say, obviously, for those who be less used to this field, obviously, we're not talking about STEMIs, because if you have STEMI, most of the time you're going to cath lab, the vessel's totally occluded, and what you want to do is primary angioplasty. You know, we do thrombus collection, primary angioplasty, restore flow. We were talking about those in which you have a bit more time to think about what you're doing.
Any other question from the floor for Dr. Tardif, who's going to be leaving, so he will not participate in the panel discussion?
And I have to apologize for leaving early.
Not a problem, but if I can abuse you for this audience, do you, as a cardiologist, have any residual issue with sulfonylureas that have long been blamed to, you know, with the business about post-ischemic reconditioning and stuff like that?
Well, so you're asking a diabetologist asking a cardiologist about SU, so I need to be careful. What I would say is, as a cardiologist, I tend to be fairly concerned, nervous about hypoglycemia.
Right.
I have no problem, and I feel very comfortable with metformin as a, you know, I can even prescribe as a cardiologist metformin. That I feel comfortable with. I stopped stopping metformin before CAT a long time ago, although it's still in the guidelines of some people. But this, I think, the risk of renal dysfunction after CAT is so low that it's silly to stop metformin temporarily in these patients. As far as SUs are concerned, and the issue you raised, this is not a big issue in my mind. And if you were suggesting earlier that, you know, should we stop an SU, because most of the time, actually, we let our diabetes cardiologists, diabetes colleagues
to deal with it.
Take care of that, yeah.
Right. What about GIK, glucose, insulin, potassium infusion?
Personally, I'd love to hear what others are doing, but this is not something we've been using in the last years, in part because of results of the DGAMI-2 study. Would you agree?
It may be because you don't control the glucose, because if you give a fixed infusion of glucose and insulin, the insulin-sensitive patient will be at risk of hypoglycemia, the insulin-resistant patient will be at risk of hyperglycemia. What would really be needed is a clamp. You know, I'm a clamp maniac, so, but you may run both risks and compound, you know, the benefit with the risk, and this may be the reason why small studies have been positive, but
yes,
big, large trials have not produced a positive result. So
exactly. The other thing we haven't...
Because the idea itself seems to be quite reasonable, doesn't it?
Oh, I mean, sure.
Repolarizing the, you know, and limiting the extension of the infarct.
No, I agree with that. The thing that perhaps we haven't discussed too much up to now, and hopefully will be covered later on, is I said that diabetes is actually the tip of the iceberg in ACS. You have, you know, 50–60% of patients that have glucose, you know, metabolism dysregulation, and a lot of these patients are actually have diabetes or will have diabetes in the next few years, and I think we need to address these patients and be aggressive with those patients as well.